Good morning. Today I would like to talk about medications in review for the Module 7 examination that you will soon be taking. Anytime that we begin talking about medications, I think it's important to talk about two terms, antagonist versus agonist. You have to remember your medical terminology, the AN and A. An agonist binds to a specific receptor site in the body, producing an alteration in biological function and resulting in a desired effect. Antagonist, then, the AN becomes important here. It binds to the agonist receptor site, preventing the agonist from binding here and causing its desired effect. Consequently, it works against. The first set of medications I'd like to talk about are anticoagulants, coagulants, and reversals. The two main drugs here for coagulants are heparin and Coumadin. Heparin is what we are most concerned with. It is a drug that is given IV or sub-Q. Coumadin, on the other hand, is an oral medication. Typically, people will take postoperatively after surgery. The two drugs that counteract the coagulants are protamine sulfate and vitamin K, so they act as anticoagulants. In the open heart room, we give large doses of heparin in order to keep the blood very thin. And then at the end of the case, when we would like to thicken the blood back up, we will actually inject the patient with protamine sulfate, which reverses the heparin. Next set of medications I would like to discuss are steroids versus non-steroidal or NSAIDs. Steroids decrease inflammation. Many of the steroids that we give in the operating room are listed above: Decadron, Solucortef, Solumedrol, and Celestone. They decrease inflammation by suppressing the immune system. Decadron is given to many of our patients, our children, who actually have tonsillectomy surgery, and that way at the end of the procedure, they do not end up with swelling in the back of the neck. NSAIDs, on the other hand, are frequently given in the postoperative PACU area. They are non-steroidal anti-inflammatories such as Toradol, given typically for moderate pain control. Antibiotics. Antibiotics is a very long list of medications. I have included some of the classifications of antibiotics here, such as aminoglycosides, penicillins, cephalosporins, Ancef being the big one there, are antiprotozoals that we use when we do colon resections, such as Flagyl. Many of these antibiotics that you see listed on this page, bacitracin, neosporin, vancomycin, come not only in IV piggyback form, but also in ointment form. Bacitracin comes as a powder that has to be reconstituted. Vancomycin, many physicians now are trying to stay away from because of the fact that we have a lot of vancomycin-resistant staph infections, typically which came about because of overuse of antibiotics, especially vancomycin. The last slide here does have a few more antibiotics. Ciprosilvadine. Silvadine is used many times in cream format on our burn patients. Very effective for burns. And the number one complication status post-burn is infection. Emergency meds. Extremely important that you know these and why they're used. Remember, many of our medications actually have dual uses. The first one, for instance, lidocaine, which is an antiarrhythmic, also can be used for local, but In this case, listed under emergency medications, I have listed lidocaine as an antiarrhythmic on top of procainamide. The second one there is an antihistamine, Benadryl, the same Benadryl that is over the counter. So if anesthesia by any chance happens to give a patient an IV antibiotic and they end up with rash, Benadryl can be administered IV to counteract some of the systemic reaction that patient is having from the medication that they might be allergic to. Another one listed there are antihypertensives. Antihypertensives are medications given to reduce blood pressure. Nitro, Nipride, Nitropress, a couple of them listed there. The fourth one on this slide is coronary artery dilator, nitroglycerin being listed. It decreases the cardiac preload and systemic vascular resistance, therefore increases coronary artery blood flow, many times used for heart attacks or chest pain. The second slide of emergency medications listed, the first one is sodium bicarbonate, used to treat metabolic acidosis, especially in cardiac arrest. It can also be used as an electrolyte replacement. Levophed, a cardiac med, the old saying, Levophed, leave them dead, used to treat cardiac arrhythmias. It is a potent vasoconstrictor and is known to elevate blood pressure in patients where the blood pressure has dropped to extreme levels. The third drug, epinephrine or adrenaline, is the first drug of choice given during a heart attack or a code situation. Epinephrine is used for the treatment of shock and or cardiac and respiratory failure. The last drug on this slide is theophylline or aminophylline, typically given to relieve bronchial asthma, used for emphysema and or pulmonary edema. Some other emergency medications, some of the cardiac emergency medications, Isoprel, used to stabilize the heart rate, strengthen the heart contractions, used many times during heart block or ventricular arrhythmias. Another drug listed there, Normandine, reduces peripheral vascular resistance, used during a hypertensive crisis. And the last drug on this slide is Lanoxin or digoxin, which is used to strengthen cardiac contractions, used many times in individuals with heart failure, patients with supraventricular tachycardia or atrial fibrillation. Dig is used frequently, taken orally by people at home. The last slide with emergency medications includes atropine, which is used to enhance the AV conduction. It does increase the output and raises the heart rate. Used many times when we are in the GI lab to help decrease secretions. Second drug, calcium chloride, increases heart contractions, typically not given with sodium bicarb. And the last drug there, aramine, increases cardiac output, blood pressure, and treats hypotension. In this next slide, I talk about malignant hyperthermia, or MH. Malignant hyperthermia is a crisis situation, hopefully that none of us will ever see. Many times the patient does not survive a hypertensive crisis. It is a hereditary disorder, can also be caused by stress, but typically is triggered by a nectine or succinylcholine. The drug of choice to counteract a MH crisis is dantrolene or Dantrum, and it works by interfering with the calcium transport in the skeletal muscle, reducing the contraction. Typically, the signs and symptoms that one will see in the operating room, usually first visualized by the anesthesiologist, are muscle rigidity, CO2 waveforms begin to get off, and eventually the patient's temperature goes way out of control. Diuretics, first one listed there is Lasix, typically used in pulmonary edema and hypertension. And the next one listed is mannitol or osmotrol, used for generalized edema in presence where individuals have not produced a lot of urine input or urine output secondary to impaired renal function. Mannitol typically used with many head trauma cases. Blood and blood substitutes. The list is there on the PowerPoint slide. Whole blood, not frequently given. Typically what is administered in the operating room is packed red blood cells. And the next one listed is plasma or fresh frozen plasma, FFPs. FFPs are used when there is a need for clotting factors. So anytime anesthesia begins to administer many units of packed red blood cells, there will be fresh frozen plasma given at the same time in order to also replace the clotting factors in somebody's blood. Fresh frozen plasma is frozen, and therefore the blood bank will need to be alerted prior to wanting to give it because it has to be thawed. Dextran is a large sugar molecule product that does not diffuse from the intravascular space. It may prevent clotting for a short period of time, typically used for hypovolemia or hypovolemic shock. The last of the blood products listed are the plasma expanders such as Hedestart or Hespan, which expands plasma volume and provides fluid replacement with hypovolemia or hypovolemic shock. Many times this product is given to patients who refuse to have blood transfusions. Depolarizing versus non-depolarizing neuromuscular blocking agents. The one depolarizing neuromuscular blocking agent is succinylcholine or nectine. The one classifying factor with this drug is the fact that it causes fasciculations, kind of a clonic type seizure activity by the patient. Very short term, but you can see the patient fasciculating on the table. Therefore, anesthesia knows that the drug has taken effect and they are able to intubate the patient. These drugs are actually given to paralyze the patient for intubation purposes and many times while we are conducting surgery. The non-depolarizing agents are listed there. There are several of them. The one that typically some people may or may not have heard of before is curare, used years ago by the Indians to poison their arrows when they are out hunting, killing animals. Inhalation agents. The first I've listed is oxygen. Oxygen is not classified as an anesthetic agent, but is used on most anesthetic administrations. Therefore, I thought it was important to put it on the slide. Nitrous, NO2, comes with or in the blue cylinders or connects with the blue gas hose to the hospital gas line. They're very relatively short acting, does act fast, freely diffuses closed spaces such as bowel and the tympanic membrane. Consequently, it is not used when we do middle ear cases other than maybe to induce the patient, and then after that the nitrous oxide is typically shut off. When we go to close on bowel resections, many times the surgeon will ask the anesthesiologist to discontinue the use of nitrous oxide for the same reason, so that the surgeon can get the abdominal wall closed and not have the bowel expand. Volatile agents are listed on the next couple slides. The first one is SIVO, or Ultane. It is an odorless agent, very rapid onset and recovery, does not cause liver damage, but is a little expensive. The one under that is your desoflurane or Suprane. This is the only agent that actually requires a heated vaporizer. It does have a pungent aroma, typically therefore contraindicating its use during inhalation induction, although it is less expensive than SIVO. The last two on this slide, Forane and Ethane. Forane is popular, although it too has a mild, pungent, musty smell. Also not used on procedures usually involving the head because it does have a tendency of increasing intracranial pressure. Ethane is less commonly used anymore today. Other medications of value worth mentioning are one dissociative agent is ketamine. It is possible that you have heard of the vitamin K parties. Ketamine not frequently used in or with adults because it does have a tendency of causing hallucinations. Used frequently in oral surgery, dental surgery with individuals who have a little mental retardation or perhaps Downs, where anesthesia does not necessarily want to put them under general anesthesia, and perhaps give them ketamine, very kind of short acting, puts them in a little bit of a hallucinated state where the surgery can occur and they are not aware of what is going on. Induction agents. First one listed is propofol or Deprivan, the Michael Jackson drug, the milky white substance. Amidate listed there. Sodium pentothal, our old truth serum drug. I have not seen this drug used in probably 10 years. And the last one listed is Brevital. Brevital is a very fast-acting drug given to patients many times when the anesthesiologist would like to do a eye block, like a retrobulbar block, or if we're doing EEG treatments or shock treatments or repairing broken noses where the procedure is literally a fast 15-second procedure. Opioids are narcotics which also produce sedation. They are class 2 controlled substances. The two I have listed here are morphine and meperidine or Demerol, not frequently drugs that we are giving in the operating room, but drugs you should at least be aware of. Morphine does cause bradycardia, but is used to control severe pain. Meperidine or Demerol, typically used for moderate to severe pain, can be given IV and or IM. The last of the opiates, more of what we would see utilized in the operating room, are fentanyl or Sublimase, Sufenta, Alfenta, and Altiva. The one narcotic antagonist I have listed here is Narcan or naloxone. Many of you may or may not have heard this. It has frequently been in the news reports. There's been debate and discussion about whether or not police officers should carry Narcan so that when they come across a drug addict, they would be able to immediately administer Narcan and immediately reverse that drug overdose an individual might be experiencing. Benzodiazepines are your sedatives, tranquilizers. They reduce anxiety, apprehension. Diazepam or Valium not frequently used in the operating room. Typically, some people are instructed to take this at home prior to coming in. Midazolam or vitamin M is our Versed, very nice drug, used a lot with patients because it also causes amnesia. So once patients hit the operating room, they don't remember much of what has transpired. The second one is droperidol. Droperidol or enapsine, used for mild amnesia and frequently sometimes used to reduce nausea. I now have a series of questions, which for those of you that were unable to participate in the face-to-face Blackboard Collaborate session, will have to go through the PowerPoint slides on your own and try and respond to these series of questions that you will now see. I will read them off. As we do the face-to-face Blackboard Collaborate session, we will go through these questions and talk about them and answer the questions. First question is, name an anticoagulant that can be given oral, IV, and sub-Q. Which of them listed below is the one that's given IV? Anticoagulants are reversed by using what medication? Anti-inflammatories can be non-steroidal or steroidal. Which below is the steroidal medication? Which of the medications in the list below is an antibiotic? Which of the medications below is an IV diuretic? Which of the medications below is typically given as a substitute of blood? Which of the following medications is considered a dissociative agent? Metabolic acidosis is a concern for an anesthesiologist. Which drug below is used to treat it? What is the drug given during an AMH crisis? Which of the following medications is a depolarizing muscle relaxant? Inhalation agents requiring a heated vaporizer are which of the following? Name the opiate given at the end of a procedure for pain relief. Which drug is given as a relaxant that also has an amnesia effect? Which of the following drugs is given to prevent nausea? Also can be a relaxant. Which drug is typically given for shock and respiratory and cardiac failure? And that concludes our questioning. At this point, I will address any questions that those of you that are in the face-to-face session might have. If you would like to type them in your chat area below, I would be more than happy to respond to them one at a time. Those of you who are virtually watching this via the YouTube video, you will have to answer the questions. And if you have any questions, please don't hesitate to email them, and I will respond to them as soon as I get the questions. Otherwise, I would like to thank all of you for participating, and I look forward to conducting more of these type sessions in order to enhance and strengthen the connection between the classroom and the clinical site. Thank you.